Welcome, everyone. Today we're taking a really deep look at clindamycin. That incredibly versatile, but let's be honest, sometimes controversial antimicrobial agent. We're going to get into its therapeutic uses, some of the finer points of how it works in the body, and most importantly, the critical things you absolutely have to consider as a clinician. All right, so let's just jump right in with the big question that really frames this whole conversation. When you decide to use clindamycin, are you grabbing a powerful, precise tool for the job? Or could you be overlooking a hidden risk? Getting that balance right is everything when it comes to using this drug effectively. So to figure that out, we're going to walk through how a clinician thinks about it. First, when to even use it, then how to get the dose right. We'll cover side effects and interactions, some really critical warnings about resistance, how to handle special patient groups, and then we'll wrap up with the big takeaways. Okay, Section 1. When to use clindamycin. So first things first, let's nail down exactly when you should even be thinking about clindamycin. What are its primary jobs, and where does it really stand out from the crowd? All right, to make this real, let's think about a case you've probably seen. A patient comes in with a really nasty jaw infection, originating from the teeth. But here's the catch. They have a documented severe penicillin allergy. So your first-line drug is out. This, right here, is the classic scenario where clindamycin steps up as an absolutely crucial and often life-saving alternative. And this really shows you just how broad its use can be. You've got the really serious stuff like anaerobic infections. Think gas gangrene. But then there's this really clear pattern, right? It's the go-to alternative for people with penicillin allergies. We're talking group A strep, nasty bite wounds from animals or humans, those jaw infections we just mentioned, and it doesn't stop there. It has a role in pelvic inflammatory disease, some specific staph infections, and even as a topical cream for things like bacterial vaginosis. All right, so now we're on to Section 2, administering the correct dose. Knowing when to pull it out of the toolkit is one thing, but getting the dose right, that's the other half of the battle. And believe me, the little details here can make a massive difference for your patient. So check this out. This is a super important dosing adjustment for surgical prophylaxis. Your standard dose is 600 milligrams, right? But for patients with a body weight over 180 kilograms, that's just not enough. You have to bump it up to 900 milligrams. And this isn't just a guess, it's backed by data. Studies have shown that patients in this weight class who get less than 10 milligrams per kilogram actually have worse outcomes. It's such a simple change, but it has a huge impact. And as you can see here, the dosing is really all over the place depending on what you're treating. For something severe like pelvic inflammatory disease, we're talking high-dose IV, 900 milligrams 3 times a day. But for a jaw infection or gas gangrene, it might be 600 milligrams. Then you switch to oral for PID follow-up, and the dosing changes again, 454 times a day. And of course, for bacterial vaginosis, a simple topical cream does the trick. The bottom line is you absolutely have to tailor the route and the dose to the specific infection. Okay, so now for Section 3, navigating side effects and interactions. Because let's face it, no drug is a free ride. There are always potential downsides. We have to be super vigilant about side effects and know what other meds it doesn't play nicely with. This is really where good clinical judgment comes in. So you're going to see some common stuff, right? GI complaints, maybe a weird metallic taste in the mouth. But the thing you have to be laser focused on is diarrhea. Any diarrhea at all during or after a course of clindamycin should set off alarm bells for C. diff, or CDI. It is a massive red flag. And get this, even the topical cream can be absorbed into the system. It's rare for sure, but there are reported cases of pseudomembranous colitis even from topical use. So you got to be careful. Now, what about drug interactions? There are 2 big ones to keep in your head. First, rifampicin. If you give it with clindamycin, it can actually lower the clindamycin levels in the blood because it revs up the CYP3A4 enzyme. Now, the studies are a bit mixed on whether this actually leads to treatment failure, but it's something to know. The other one is more acute, aminoglycosides. Put them together with clindamycin and you can get a synergistic effect on neuromuscular blockade. So if your patient is getting muscle relaxants, you have to be extremely cautious. All right, Section 4, critical warnings and resistance. Now we're getting into the really serious stuff. We're going to talk about the biggest dangers and a really fascinating but also really dangerous mechanism of resistance. Okay, this is a concept you have to understand. It's called inducible resistance. Think of it like this. Some bacteria, especially staph, have a secret weapon, a resistance gene called but it's a sleeper agent. It's totally dormant. It only wakes up and gets expressed when it's induced by another antibiotic, like erythromycin. So the lab test might come back saying, hey, this bug is susceptible to clindamycin, but then you give it to the patient and boom, the resistance gene gets switched on and your treatment fails. It's a real trap. So how do we spot this hidden threat? Well, the lab has a pretty clever trick up its sleeve called the D-zone test. What they do is they take an agar plate and put an erythromycin disc right next to a clindamycin disc. The erythromycin acts as the trigger, waking up that dormant resistance gene. If the bacteria has that gene, the enzyme it produces will start blocking the clindamycin nearby, and you get this classic flattened D-shaped zone where the bacteria won't grow. It's a really elegant way to unmask the resistance. And that D shape? It's a dead giveaway. If you see a D zone, it means resistant. Full stop. The isolate has to be reported as resistant to clindamycin no matter what the initial test said. If you miss this, you're setting your patient up for treatment failure. Okay, let's switch gears to Section 5, use in special populations. How do we think about clindamycin when it comes to pregnancy, lactation, or even pediatric patients? The rules can be a little different, and it's so important to get it right for safe practice. So the good news is the data here is pretty reassuring. Clindamycin is generally considered safe during both pregnancy and lactation. This makes it a really valuable option, especially as an alternative to metronidazole for treating bacterial vaginosis in pregnancy. And here's a great practical tip for lactating mothers. Unlike metronidazole, clindamycin won't give the breast milk that awful metallic taste, which can be a real problem. All right, we're at our last section, stewardship and final takeaways. So let's kind of zoom out now and think about the big picture. How does clindamycin fit into the world of responsible antibiotic use? How do we use it wisely? And what are the absolute key things you need to walk away with today? You know, a huge part of good stewardship is about de-escalation, switching from IV to oral or from a broad-spectrum antibiotic to a more targeted one. And clindamycin is a fantastic tool for this. Think about a case of osteomyelitis, a bone infection. You might start the patient on broad IV antibiotics, but once you get the culture results back, you can often switch them over to oral clindamycin. It's the perfect example of stepping down to a narrower agent. It's better for the patient, gets them out of the hospital faster, and it's a smart move in the fight against resistance. I love this quote. Sometimes it feels like we have a hammer, a screwdriver, and a wrench, but the nail is actually a screw, and the screw is actually a bolt. This just perfectly sums up the complexity of using antibiotics today. It's not enough to just have clindamycin in your toolbox. You have to know exactly what kind of bolt you're dealing with. Trying to use clindamycin on an infection with D-zone resistance, that's like grabbing a wrench to hammer in a nail. It's just the wrong tool for the job, and it's absolutely going to fail. Okay, time for a quick pop quiz to see if you've been paying attention. Here's the first question. You have a patient who needs peri-operative prophylaxis, and they weigh 190 kilograms. What's the recommended single dose of clindamycin? And the answer is 900 milligrams. Remember that key detail? For patients over 180 kilograms, that standard 600 milligram dose just isn't going to cut it. You have to make that increase to ensure they get enough of the drug to actually prevent an infection. It's a critical adjustment. All right, last question. And this one really gets to the heart of that hidden danger we talked about, inducible resistance. The lab report for a staph infection comes back, and you see that D-shaped zone around the clindamycin disc. What do? How should that susceptibility be reported? The answer is simple, and it's the only right answer. You report it as resistant. A positive D-zone test is a prediction of failure in the patient, plain and simple, even if other tests say it's sensitive. And that's really the crucial thing to take away from all of this. You have to look beyond the surface of a lab report to be a smart, effective, and safe clinician.